Good day. My name is Sharon Geaghan, and I'm a pathologist at Stanford University School of Medicine. And our topic today is, what is best practice for testing for unexpected pregnancy in pediatric and adult patients prior to cancer diagnostics, imaging, and therapy? And before we get going, I'd like to disclose that there's several companies listed, and as one of the faculty members at Stanford University, I'm required to make this disclosure before I speak. I do not believe there's any industry-sponsored research that I'm citing. If there is, I will say it is industry-sponsored. Otherwise, it can be assumed to be independent. So today our learning objectives are the following. We're going to identify sample types, test types, and performance locations of available human chorionic gonadotropin tests for unexpected pregnancies in cancer patients. We'll describe the fundamental rationale for home HCG tests and precautions regarding their use. And then we'll compare and contrast performance characteristics of available urine and serum HCG tests for diagnosis of pregnancy and what the clinical impact is of these differences. We'll detail how erroneous urine HCG results can occur, and hopefully at the end you'll be able to design and implement a testing guideline for testing female cancer patients for unexpected pregnancy at your clinical setting. So all of this really relies on a commitment to improving the efficiency and effectiveness of all aspects of healthcare based on more accurate and rapid decision making. And for me, this involves looking at laboratory tests and trying to choose the right test on the right patient, the right sample at the right time. So let's define the problem. We know that cancer patients are sexually active, and female cancer patients are often in the reproductive years of their life, yet they face a variety of procedures, both diagnostic and therapeutic, which pose teratogenic hazards if there's an unexpected pregnancy. And there's substantial knowledge gaps amongst healthcare providers, such as physicians and nurses, regarding what the limitations are of the different tests and the different sample types. So why do we test? Well, if we know that diagnostic and therapeutic procedures pose hazard to an unexpected pregnancy, and yet they're required for cancer diagnosis and treatment, why do we test? Well, women are tested for pregnancy so that decision-making regarding pregnancy and the need for cancer treatment can be made prospectively to avoid or minimize potential iatrogenic harm when it's possible, and to avoid emotional distress for the patient, as well as liability for the physician. And doing this is patient-centered care and allows for informed decisions by the patient, and these decisions are the patient's. So some of the interventions we're talking about that are typically contraindicated in the presence of a pregnancy, yet may be required for the diagnosis and treatment of cancer include, of course, ionizing radiation, diagnostic biopsy and surgical resection procedures, which also often require anesthesia or sedation, chemotherapeutic agents, of course, category X medications, which are known to be teratogenic, and nuclear medicine scans, to name a few. So at this point, I'd like to take a quick poll of the audience and ask the following question, and then I'll wait for your responses and I will share the results of the poll. So do you perform a pregnancy test on your patients before therapy? Okay, it looks like folks aren't going to answer this one. So I didn't have any results to report. Oh, we did get one. So I'll share that with you. And the person who answered did answer that they do not test for pregnancy. So moving on. Ideally, we're going to look at the patient, and the patient brings a question. In this case, are they possibly pregnant or not? We'll make a decision, and the test will help us to take an action or an outcome. And based on that principle, let's just look for a minute at the synthesis of beta HCG. So we know that it's synthesized by the placenta. It maintains the corpus luteum, which secretes progesterone, and the levels consistently increase in early pregnancy, and then they drop. So based on that, we want to choose the right test at the right time. So let's start with the idea of analytic time versus therapeutic time. So when we talk about analytic time for testing, that includes obtaining the specimen, transporting the specimen, and obtaining the test results. Therapeutic time, on the other hand, begins with the order from the physician and ends when a therapeutic action is taken based on the test result. So we often think of point of care testing as a good option for reducing turnaround time. Let's give an example here. So when we use a handheld point of care analyzer, such as the iStat in the radiology suite, it is to support the standard of practice, which is to review a creatinine prior to contrast injection. In this case, a creatinine done in the laboratory takes too much time, and it would hold up patients from going through the MRI or the CT scan, which requires good patient throughput in terms of paying back the return on investment. If the creatinine is elevated, a more expensive contrast medium is used to minimize risk of further kidney damage and fibrosis due to contrast medium. But inevitably, not all patients come with their creatinine in hand. And so for the unscheduled scan due to an emergency or a sudden deterioration in the patient, these unexpected studies require creatinine, which is not available from the laboratory in an adequate turnaround time. Therefore, the point of care creatinine is available. So this optimizes patient throughput through the scans, and it provides a very excellent cost benefit. So now, going back to our predicament of patients appearing for cancer treatment or diagnostics in their reproductive years who may be pregnant, let's look at what we have as options. We have two types of test sample, either urine or serum, and that to a large degree determines where the test is going to be performed. So the urine requires patient to produce the urine and collect the urine. And although that sounds very simple, those of us who have waited for a urine sample know that actually it takes a lot longer than you might think. There's possible delays, therefore, from that aspect. And then the specimen can be tested either at home or at the point of care. Whereas for serum tests, blood can be collected readily, but does require an available phlebotomist, so you can have a delay there. But the serum must be separated from whole blood in the laboratory prior to testing. So non-laboratory personnel cannot separate whole blood into serum, which is the specimen required for that type of testing that's done in the laboratory. So what about testing time? When do we test? Well, there's various protocols. Some individuals are tested the same day, and others are tested sometime is a pre-op visit, usually within 10 days or 14 days before the procedure. So this study, I think, very nicely showed what is the impact of testing the same day versus in the 2 weeks prior to the procedure or the intervention. So they looked at this, and they were looking at the incidence of luteal phase, very early pregnancies in which conception occurs before the planned procedure, which in this case was laparoscopic sterilization. They retrospectively reviewed their cases for so-called sterilization failures. In other words, the individual underwent tubal ligation for sterilization purposes, and yet they had a pregnancy. And this was after there was a negative urine HCG test done within 2 weeks prior to their procedure, preoperatively. In these cases, they found a rate of 7 in 401 cases, there were 7 unexpected pregnancies, which is a rate of about 17 per 1,000. When they instituted same-day pregnancy testing, also using urine HCG tests, so they were comparing apples to apples, they found 8 pregnancies and were able to cancel the procedure in those 8 pregnancies out of 605, which is a rate of 13 per 1,000 pregnancies. And this was, all of these cases were following a negative urine pregnancy test within 2 weeks. So the same day testing picked up an additional number, which was significant, 8 out of 605. So basically what they said was they looked at last day of the menstrual period, they looked at ultrasound records and date of delivery and so forth, and they determined the time of conception for these cases. And the false negatives that occurred when the testing was done within the 2 weeks prior to the procedure, the date of the pregnancy was determined to be between 18 and 39 days from the last menstrual period. So given the sensitivity of urine tests, really a couple of those, certainly the 39-day pregnancy, should have been discovered, even though the test was not done the same day of the procedure. However, there's a known risk of false negative pregnancy tests with urine tests, which we'll describe in a little more detail later. For the others, they were a little too early for the positive pregnancy test prior to the day of surgery. So let's talk for a minute about what it means to have a positive pregnancy test in a cancer patient. If the test is being done by the lab, which is separate from where the location of the patient is, or if the test is being done at the bedside as a point of care test, in either case, it really represents a critical value, though it often is not on the critical value list for an institution. So what is a critical value? Well, the concept of critical value was introduced several decades ago, and it was defined as a certain derangement, pathophysiological derangement of such variance with normal as to be life-threatening if therapy is not instituted immediately. And it has basically grown from that original definition to include results for which immediate action must be taken. And therefore, critical values must include a physician notification. So it can't just be electronically available. It has to be notified directly to a physician, and that's a standard of practice today in laboratory medicine. So a critical value of a positive pregnancy test for chemotherapy patients that are female is certainly worthy of immediate action, because we know that administration of chemotherapy to the fetus has potentially irreversible and damaging effects depending on what the agent is. So I'm just highlighting that because it's very important that a positive pregnancy test be communicated immediately to the healthcare providers. So future directions for laboratory medicine, we may be able to determine that this needs to be a critical value report and use outcome-based evidence to define all of our best practices in critical value testing and report for special groups of patients, such as cancer patients, because obviously a pregnancy test is not a critical value in other types of patients, but we can use our clinical informatics in the future, use tools to support specialized care so that it would be recognized that this is a cancer patient in the day hospital where chemotherapy is given and that a positive pregnancy test should be called. So that's just a note for the future as we develop our clinical informatics tools. So what about home testing? Many patients that we see now have done home testing or are doing home testing. So what's the rationale there? Well, the US FDA, which regulates all of this, states that home tests can help detect possible health conditions, even when you have no symptoms, so that you can get treatment, and specific conditions that they mention where there are no signs, where you can take immediate action is pregnancy testing. Perhaps you won't take medications or take recreational drugs or alcohol if you know that. you are pregnant. And it can also help monitor conditions that require frequent changes of treatment. Blood sugar monitoring diabetics has been a great success story. Yet there are provisions that this can be, that home tests must be used with precautions, so that you shouldn't replace visits to your doctor with home tests. You should talk about your test results with your physician, and the physician can best evaluate them in combination with your medical history and so forth. And so these are the cautionary notes that the FDA points out in terms of home testing. So pregnancy home testing is considered a no-brainer, essentially. And yet our testing rationale in the point of care arena is that the influence of training and competency assessment really impacts laboratory testing more generally, both the performance and the outcome. So I would like to cite this study that was done of over 600 laywomen who are doing home kit pregnancy testing, and what it showed about home testing and some of the perils. So basically, the age of the women were over the reproductive years, and you can see there were 3 age groups, from 14 to 24, 25 to 39, and 40 to 49 years of age. And they represented, they wanted it to reflect the study population to reflect the general population. So they had urban patients, rural patients, both professional and non-professional, various degrees of education. So I'd like you to look at this distribution and think to yourself, who do you think is going to do best at home testing? Is it going to be the young folks from 14 to 24, or would it be the more mature individuals in their 40s? Would it be professionals that would be better at this, folks from rural areas? What do you think? And then I'll show you what was found. So first of all, this is kind of a detailed chart, but basically what I'd like you to see is that there were 27 kits on the market for pregnancy testing, and only those that had excellent sensitivity, like 100%, and specificity were chosen. So if you look at these results, which were done by clinical laboratory technologists that are licensed, they wanted to basically give our study participants the best chance to do well. So they only took 11 of the kits that performed very, very well in the hands of licensed chemistry technologists. So that being said, they went on and they looked at how many have a high dose hook effect. Now, hook effect is really remarkable when you see a very pregnant individual that's clearly pregnant, and yet they have a negative pregnancy test. Why does that happen? Well, these tests are based on a certain amount of reagent, and in very, very high HCG levels, you can see that despite the very high levels here, over 40 or over 30,000, there are some negative tests, some negative pregnancy tests, and that is known as a high dose hook effect, where basically the amount of the analyte overwhelms the test system. And so it actually does not give you the correct response because of the extraordinary excess of the analyte that's being looked for. So you could see that a number of the kits suffered from a high dose hook effect. In other words, giving a negative test despite a large degree of HCG being present. So now let's look at the sensitivity and specificity in these kits tested by the 600 odd laywomen. So they were tested at 2 different levels. So the first, I'll get my pointer here. The first column here is, just see here. The first column here is at twice the manufacturer's detection level. And you can see in this column, the sensitivity, in other words, how many truly positive at twice the detection level, HCG samples were actually tested positive. Only one kit was 100%, and only, I think, about 3 were over 90% in this leftmost column, which is really surprisingly poor. At the manufacturer's detection limit, which is U plus here on the right, the performance was, of course, worse because this is more at the detection level. There was only, I think, 2 of the kits that tested over 90% sensitive. So this is very concerning. And now when we get to our next slide, we'll look at what was the influence of socioeconomic factors on the participants on false negative results. So of course, false negative results is what we don't want. It's where the test says that there is no pregnancy, but in fact there is. Well, the false negative results by age were 39%, 35%, and 36%. So extraordinarily high, well into the 30s, real pregnancies being diagnosed as false negative despite the age of the individual doing the testing. Professional activity, moving down this chart, was not important at all, whether it was yes or no. There was a similar, almost identical false negative result of 36, 37%. And lastly, academic training and degree of education, again, was not statistically significant. And the false negatives were again, very, very high. So this would essentially mean that an individual would go ahead and take their medication, or take alcohol, or whatever the item might be that would not be suggested in the setting of pregnancy. Yet I don't want to give the idea that in fact that home testing is not recommended. I'm actually very supportive of home testing. I think that the manufacturer's instructions and the patient performance are key. And I'd like to just highlight, in contrast to those data I just showed you, that in the arena of home prothrombin testing and INR monitoring on patients with Coumadin, there have been several multi-center studies that show patients can perform as well as professional with point-of-care home testing for prothrombin time and INR. Multiple multi-center studies show that after just a little bit of training, patients could even correctly make dosage changes, which is not in their purview, but I think it just highlights how well they can do. And I have a reference here at the bottom, if this is an area of interest, that does a very nice review and meta-analysis of all this literature, which is very exciting because it shows what patients can do when they have the proper instructions, when they read the instructions, and then they can perform competently and they're motivated to do so. So let's go back to our pregnancy testing. So there are a number of operational issues. So point of care testing of urine is often favored because it can be performed outside the clinical laboratory, and it's got a very fast turnaround time. So it doesn't require any processing, it doesn't require transport, it's just done at the bedside. But it has a higher false negative rate than serum tests. So if you're going to opt for the serum test, you have to build it into your workflow, and it has to be taken into account in scheduling procedures. Whole blood point of care testing are on the horizon. That will allow you the sensitivity you want, like a serum HCG test, but there's no processing of the blood. It can just be done on whole blood, much like a glucose meter. These are not yet commercially available in the United States, but several vendors have developed them and will soon be available. So what this will offer, once again, is a point of care test on whole blood that can be done with a fast turnaround time and very excellent sensitivity at the bedside. So that's something to look forward to, probably in the new year. So this may be a bit technical, but I do have references if people are interested on the analytic sensitivities, which differ between urine and blood HCG tests. And they differ to the point where the qualitative or urine HCG tests will not determine a pregnancy, and yet the quantitative serum test, which is done in the lab, will reveal a pregnancy 3 to 5 or even more days prior to the urine test. So there is a window, and this is a window of concern where the qualitative test, which is less sensitive, will not determine a pregnancy, but if one sends it to the laboratory for a serum test, it will have a positive pregnancy test. How often is this an issue? We don't have good data in cancer population, which is our population of interest in this discussion. We do have some studies that have looked at all individuals having a pregnancy test, and they found to be almost about 4% of patients test in this suboptimal zone where the urine HCG may not detect it, and even the serum HCG might be low. So it is a significant number of patients that fall in this suboptimal performance zone. Why do we have erroneous urine HCG results? Well, the pearl is that one should always ask for the first urine of the day, because that's the most concentrated. But in reality, that often is not the sample that's being tested. So you have hydration, you have dilution issues, and so for that reason, you have a possibility of a false negative. In one emergency department study, again, not cancer patients, but there's a limited literature here to review, there was about 0.5% of urine pregnancy results in error. They were due oftentimes to documentation errors, because much of this point of care testing is actually done with manual documentation, which I'll talk about in a minute. There was also insufficient sample issues. Again, making urine is not as easy in these types of settings as one would think. There was also performing personnel that do incorrect reading time. There's a very particular specified reading time, and if people are multitasking, doing other things, distracted or whatever, they may not read the point of care test at the correct time. And we've talked a little bit about hook effect and interferences. So there's a concept called therapeutic yield. Now, in this case, a serum HCG is more expensive and takes more time than a urine HCG. But one way to look at this is that how many times do you have to do a test, and how many times does that measured result in therapeutic changes? And you divide that by the total number of time you do tests. And this is a utilization metric. So in other words, you do an albumin test a lot. They're done every day on patients. Unfortunately, sometimes more than once a day as part of chemistry panels. But it's been shown in the literature that you rarely change any action whatsoever based on an albumin test. Whereas here we're dealing with a pregnancy test for which a positive pregnancy result would definitely make for changes in therapeutic actions or delays in those actions. So in this case, I think if you look at the therapeutic yield, you'd only be doing a test the once, but you'd be definitely acting on it were it positive. So this is just a way of showing the value of a serum quantitative HCG. And just while I'm on that subject, there are misconceptions about these tests. For example, it's often quoted that there's a 48-hour doubling time if there's a healthy pregnancy on board for beta HCG, but that's been studied further, and much of this old literature actually, including the graphs that I showed you, is based on previous formulations, and there's a WHO standard that is now, that tests are being calibrated against, and in much of the past literature, it was a different standard. We're now on like the 3rd generation of that standard. So this is a problem when you're comparing old papers and old data with current data and current tests, because it actually is a different formulation. So that being said, this issue of doubling time for healthy pregnancies has been studied more recently, and the lower limits of normal are established, where beta HCG may increase only 24% in 24 hours and only 53% rise in 48 hours. That's the lower limit of normal. So it's quite different actually than is often quoted. So what about clinical informatics? What can we do about this documentation issues? If we are going to do point of care testing, it was shown that I believe it was a quarter of the results were incorrect because of documentation issues in that ED study. What I developed in my point of care department over a period of time was a way to have nurses document point of care testing. And it was put into the nursing module, the nursing notes module. It was a nursing documentation software. And what they could do is they could choose, as you see on the left, point of care testing and click on it. And then the point of care testing menu would come up. And this again was not in the lab menu because they're not clinical laboratory technologists. They're charting in a different module entirely of the electronic medical record. And here's another example where you're looking at doing a protein urine dipstick. You click on point of care testing and you click over on the right and it gives you a drop down menu and you can see that they can choose what they've seen on the dipstick and click negative or positive or whatever the result is. Another type of test more akin to looking at a pregnancy test is the AmniSure test for ruptured membranes. And this I'm just showing you because this is what it looks like to the operator. And then built into the nursing module, they click on point of care testing, they find the AmniSure test, and it is a drop-down menu that says, was it positive, was it negative? Was the control working? And the beauty of this is that it's retrievable in the electronic medical record. The documentation is easy to find. It's done at, right as the test is being done, and it allows for a more standardized and complete medical record. So now we've talked a little bit about some of the different issues with the testing, but what really is best practice? Can we say what best practice is? Well, I'd like to show you two studies. There's no published literature in the US about what people are actually doing. But there are two studies published, one from Australia, one from Ireland. So the Australian study demonstrates very inconsistent practices of preoperative assessment of pregnancy status in hospitals performing, in this case, it was surgery, which could potentially result in adverse incidents for the pregnancy. So 68% of these respondents said that they had guidelines for preoperative pregnancy testing. 55% said all women are tested of anyone of reproductive age, and 33% said that they had seen patients who had presented for surgery unaware that they were pregnant, and generally about 3/4 felt that all women of reproductive potential should have routine preoperative testing, and 89% supported the introduction of national or statewide guidelines. So that was very interesting. And from Ireland, from Ireland, a survey of 9 different teaching hospitals in Dublin looked at what practice really is. And about 20% of respondents had a patient with a false negative urinary pregnancy test, which was later discovered. 35% said that they routinely informed patients of the need to avoid pregnancy before surgery of the gynecologist, but only 14% of the surgical specialists advised that. And so that's certainly something that can be built in to a cancer center protocol, is that perhaps at the time of the first round of chemotherapy or before it, that even children and teens who are sexually active, as we know, as well as adult females, be advised to avoid pregnancy and have a contraception discussion. On the day of elective surgery in the Irish study, about 80% determined the last menstrual period, and about half of them asked specifically about the chance of pregnancy and the contraception. 70% did a urine pregnancy test, and only 1% ordered a serum HCG. And some of these folks only tested selective people based on based on their last menstrual period. But overall, 76% supported women having reproductive potential, having the testing, and so generally, I think these studies were very interesting because it shows a lot of variability in practice, but a general support for it. So one suggestion in the informatics world has been to write a rule in the order entry when you are ordering category X medications, which could have an adverse outcome on a pregnancy, on anyone over a certain age. In the state of California, many have chosen an early age, like 11 or 12, and that you would order a test and it would be automatically fire when you are ordering this type of medication. So I'd like to make another poll, and the poll that I'd like to do now is question number 2. I'm going to push it out and see what attendees have to say about, do you choose a urine pregnancy test on your patients currently, or do you choose a blood test for unexpected pregnancy in your patients? So we're collecting answers now. The answers are either yes, no, or not sure. And I'll give another little bit of time before I close the poll. Okay, and here are our results. Okay, so so we had some folks that are not sure and some others that answered positively. The wording of the question probably wasn't the best, but I think that's, in my experience, I really think that that's very typical, because I don't think that it's always clear to a physician or a nurse practitioner who the individual is ordering the test what test they're actually getting and what are the limitations of that test. And I truly think that as a pathologist, that's something we need to do better with is truly educating folks about what they're getting, what are the false negative rates, and so forth. So I just want to sum up, and then hopefully we can go to some question and answer period. I'd really like to hear from the audience. First of all, we know that serum pregnancy tests have been systematically demonstrated to have greater analytic and clinical sensitivity, and they are associated with reduction in false negative pregnancy tests in multiple independent investigations. Urine pregnancy tests are unreliable in early pregnancy due to variable concentrations of urine and variable hydration status in the patients, as well as some interferences. We talked a little bit about the high dose hook effect. We talked about manual documentation issues that make it hard for the pregnancy status to be known by all the individuals taking care of the patient. And so the role of the laboratory is really to ensure that quantitative, reliable HCG tests are available in a timely fashion for clinical decision making if they're ordered from the laboratory. What I think is really exciting is that in the United States, within the next year, we're going to see whole blood HCG point of care tests that won't require being sent to a lab, that won't require processing, and it will offer excellent sensitivity combined with expedited turnaround times. And I have abstracts. I'm on the point of care testing resource committee for the American Association of Clinical Chemistry, and we had some nice abstracts. If anyone's interested, I'd be happy to send them in our recent annual meeting that showed very nice performance characteristics of some of these new this new R&D that has allowed us to look forward to a better test at the point of care. So we know that healthcare personnel are concerned. We have the surveys from overseas about unexpected pregnancy in female cancer patients of reproductive age, but there's lack of knowledge and confusion about the limitations and appropriate use of urine and serum HCG tests. There's clearly variability in testing practice evident in what is a limited published literature, and we don't have the establishment of practice guidelines. We know that manufacturers are responsible for provision of improved labeling and package instructions for home test kits, which certainly have a place in the medical home. And pathologists serve to educate and inform the accountable parties in healthcare settings. I think we should consider professional society consensus practice guidelines, and I hope to hear from you now with a question and answer period. And moving ahead, I think we can all reduce the risk of iatrogenic harm, additional emotional stress for cancer patients due to undetected pregnancies that they weren't informed about, and also reduce physician liability by using the right test on the right sample at the right time, which in many cases is going to be, for now, quantitative HCG on a serum sample prior to the important diagnostic procedures and therapeutics, ideally same-day testing. If that can't be done, certainly a urine test is certainly better than no testing at all, and it's our responsibility to all develop best practices to help protect patient safety. Thank you. I'd like to invite your questions now. We don't have a question right now, so I have one more question for you. Let's see. Trying to pull it up now. Okay, I pushed out the last poll question for you folks, and I'd like to hear, it's open now for your answer. The question is, does your clinical setting have a written policy on testing female patients for unexpected pregnancy before procedures or therapy? And I appreciate anyone who's in the audience to go ahead and answer. Okay, so it looks like we have some folks answering. So this was a question to just assess if the audience members know that they have a policy, or whether they perhaps don't know, or just to get a sense of what's out there, because there really isn't any literature published from the US at this point in time. Okay, so I've closed the poll, and now I'm pushing out the results, and you can see them. We have a not sure, and we have a yes. So just a couple of responses. So once again, if there's any questions, I'd be really happy to answer them. I'm going to go to the next and last slide, because I'd like to thank you for attending today. And if you have any follow-up questions, or you'd like to have any of the references or discuss this issue, I'd really be happy to hear from you at sgeag@stanford.edu. And I really appreciate your attendance. Thank you.